This program is brought to you by Emory University.
It is my pleasure this morning to introduce Dr. Gina Lundberg, who is well known to us. She has presented at this conference before, and I always appreciate volunteers. And she did volunteer to give this talk. And thank you for being flexible, because this was slated to be given earlier, but we had to move things around. Dr. Lundberg is a preventive cardiologist and professor of medicine, and also the clinical director of Emory Women's Heart Center. She serves on many leadership positions, and if I could just summarize the ones that I think should be highlighted here, although there were so many that would be here all morning talking about her leadership roles. She is the American College of Cardiology WIC Leadership Council Chair, the AHA Clinical Cardiology Leadership Council, was also the founding chair for the Diversity and Inclusion Committee at the Georgia ACC. She's a national spokesperson for AHA and has been for several years, and also the National Lipid Association. Dr. Lundberg, one unique thing about her is that she was named top 10 female cardiologists on social media a few years ago, and is a social media influencer in cardiology. And I think I saw that she was 13th in the world or something for promoting cardiology on social media, which is amazing. In addition to all the work that she does in leadership and advocacy, being a mentor for us in the Women's Heart Center, and really endless enthusiasm for helping women throughout, from undergrad to med school to residency. I think I get an email pretty much, several times a week where Dr. Lundberg is, involved in mentoring all of us. And in addition to all of that, she's a PI of a community service program that's a 10,000 Women Project, which amazingly she coordinates on the weekends and goes out of the community and try to recruit African-American women and screen them for risk factors and educate them. Dr. Lundberg went to Medical College of Georgia. That's where I went also. And then she trained at the Atlanta Medical Center in internal medicine, followed by her cardiology fellowship at Rush, and has been in Atlanta since 1994 and has practiced in various settings. And so without further ado, one of the things that Dr. Lundberg really enjoys is cholesterol management and treatment, and has a passion for this. And she's going to teach us today about the role of non-statin therapies in optimal cholesterol management.
Thank you, Dr. Maida. That was a very generous and kind introduction. And I just want to underscore that the Emory Women's Heart Center is a whole group of physicians and nurse practitioners, and we're a great team together, and I'm just honored to lead that team. So I do have no disclosures, but as Dr. Maida said, I'm very passionate about lipids. I personally take statins, and I endorse their safety and efficacy for prevention of atherosclerotic cardiovascular disease. So I do have a very biased and passionate opinion. So the objectives are going to be to examine the lifetime atherosclerotic risk and options for lipid-lowering therapies, to review statin side effects and intolerance. I'm going to explore the non-statin therapy recommendations and guidelines. I'm going to highlight the importance of treatment for familial hyperlipidemia, or FH, and identify some strategies to reduce risk in statin intolerance patients, and to work with shared decision-making with them. So the foundation of preventive cardiology, of lipid treatment, and in reducing cardiovascular risk factors is the basics of ABCs. And we all know blood pressure, cholesterol, not smoking, diet and weight control, good control of diabetes or prevention of diabetes, and exercise are essential. Aspirin has become more controversial, but it is still definitely important in high-risk patients and patients with acute coronary syndromes and interventions. But today I'm going to really focus on the cholesterol, but you can't ignore the exercise, the importance of it, and diet and weight control. And so I'll be mentioning them again and again. So I think we all work with patients. We want them to have a healthy lifestyle. We spend time talking about that. But in the end, it's really hard. And patients struggle to do it, every day, no holidays, no vacations, no breaks. And so we do end up using medical therapy in prevention and often, guideline treated. So this is just a little joke to get us started. So I'm going to mostly review the 2019 ACC AHA guidelines for primary prevention of cardiovascular disease. And you all may know that these pretty much just repeated and endorsed the 2018 guidelines for the management of blood cholesterol. So they're very redundant. So we're just going to go over this one. So they recommend using the ASCVD pooled cohort risk calculator as part of the initial assessment. If your patient is young, 0 to 19, do remember that in pediatrics, there is a recommendation to screen children for cholesterol, particularly high LDL, at the age of 3 and 10. This is not going on universally. You really have to remind your patients with FH, familial hypercholesterolemia, that their children and grandchildren need to be tested. But these really high-risk patients, FH patients, should be started on treatment, even as young as 10 years old, and statins and other drugs are approved. It's really the 20 to 40-year-old who I see getting overlooked for cholesterol treatments. And the guidelines is, again, if there's a strong family history, premature atherosclerosis, or an LDL over 160, we really need to consider intervening. And I just don't see the cholesterols of 140, 150, 160, particularly in the women I care for, getting the attention that they deserve. And then again, family history is so important at that age. It's probably the 40 to 75 and older that we're mostly seeing in our clinics. And sometimes the 10-year ASCVD risk is very low for what's going to happen in the next 10 years. So definitely look at the lifetime risk. You may see a woman who is, 2.7 risk now, but if you look at lifetime, it's 39%. And that is a huge lifetime risk. So don't just look at the 10-year risk. There is an immediate class 1 indication for lipid treatment with LDLs above 190, and this is very suggestive of FH. And then the diabetic patient is class 1 indication for statin use to get their LDL down to 70. And the ADA guidelines recently updated that for high-risk diabetics under 55. And you're going to hear the 55 again and again. If you have paid attention, we have these risk enhancers now, and this was really exciting for us at the Women's Heart Center because they included the conditions specific to women, such as preeclampsia, premature menopause, low birth weight baby, gestational diabetes, and pregnancy-induced hypertension. But I'm bringing it up in the lipid setting to talk about that sometimes an elevated CRP and definitely elevated LP little a, lipoprotein little a, greater than 50 milligrams per deciliter or 125 nanomoles per liter is an important marker as well. So if you have patients with lower risk, you want to look at these risk enhancers and see if they change your mind, if they push you toward a more aggressive treatment. And then they've been repeatedly offering the coronary artery calcium score. We do a lot of this at St. Joe's, and I know it's done on the Clifton campus in Midtown as well, in Johns Creek. And if the calcium score is 0 and your patient is older, particularly a 65-year-old patient, this is very good news for the patient, very low risk. But a calcium score of 0 in the 45, 50, even 55-year-old is what's to be expected. So I repeat the treatment, repeat the testing every 5 years or so until we have a score of 0 at 65. And I do want to point out that it's not just the calcium score. A calcium score over 100 is high risk, but also the 75th percentile. And I think too often we forget to look at that percentile rank, because if you have a 48-year-old patient with a score of 5, that's going to be in the 99th percentile. So don't forget, it's not just the absolute score, because the age of the patient matters. It has to do with the percentile as well. So the idea of prevention, the true value of prevention, is early detection and aggressive treatment. Currently, our disease progression is we wait till patients have an advancing age and they start to develop atherosclerosis that's clinically relevant, or they have an acute coronary syndrome, and then we start to treat statins. And at that point, we change the trajectory of the progression of atherosclerosis. A new paradigm would be, a better approach would be to start earlier in the younger patient with more aggressive treatment, risk reduction, and it might include medical management. But the point is to prevent more deaths and really fundamentally alter the course of atherosclerosis and eliminate the vast number of ischemic cardiomyopathies. So earlier treatment, aggressive treatment is the direction we're moving in. So I want to remind you of some of the old trials, 4S and FACC. These were back in the late 80s, early 90s. And even then, we were very impressed at a 37% risk reduction. As the trials moved on and we developed higher intensity statins and lower goals for treatment, you can see we've reduced that residual risk now to about 15%, but it's not zero. Lipid management is just part of the overall treatment. But if you want to know what's the difference in saying simvastatin versus atorvastatin or rosuvastatin, you're going to more than double the benefit. And so the lower targets really are important, and the high intensity statins really do give better outcomes. So when we talk about the different intensities of statins, the low intensities are pitavastatin 1 milligram, low dose pravastatin, simvastatin, lovastatin, and fluvastatin. Now, sometimes the pravastatin and lovastatin at low doses are the best tolerated. Even the patient who can take the pitavastatin 1 milligram is getting some benefit. And this is, if this is as far as the patient can go, that's certainly better than nothing. But atorvastatin 40 to 80 or rosuvastatin 20 to 40 milligrams is our high intensity statins with a usually greater than 50% risk lipid reduction. And I've seen some over responders, some high responders that will go even down 60, 70%. And then everything else is intermediate, the low dose atorvastatins, fluvastatin 40 and 80, lovastatin 40, pitavastatin 2 to 4, the mid and high doses of pravastatin and simvastatin. And nowadays, it's really not recommended to start patients on simvastatin 40 and definitely not 80, start at 20 and go up if needed. And then rosuvastatin 5 to 10 milligrams. So these are what's available to us. And there are some differences in the statins. We used to talk a lot about the lipophilic and hydrophilic, and maybe that's not as important as we used to think. I'm going to show you some information on that. But the lipophilic ones are atorvastatin, simvastatin, lovastatin, fluvastatin, cerevastatin, which is not available in America, and pitavastatin. And then the hydrophilics are pravastatin and rosuvastatin. The safest in chronic kidney disease is atorvastatin. If you're looking to boost the HDL, the best is rosuvastatin. And if you have a patient on HIV meds, there was a time that only pravastatin was approved, but now atorvastatin and rosuvastatin are considered safe as well. And many of you may be surprised that the FDA removed some of the strongest warnings using pravastatin in pregnancy. It's still not like something you want to jump on, but in a case where you really have lipid issues, it's a possibility. And you can also feel more comfortable that if your patient got pregnant early on with pravastatin and wasn't aware of it, there's less reasons to be concerned. So a recent article, hot off the press, January 2023, in the Journal of the American Heart Association, looked at U.S. trends in cholesterol screening, lipid levels, lipid-lowering medications used in adults from 1999 to 2018. So very current use of statins. And what they found is, using the most recent data from the NHANES survey, the updated trends in cholesterol screening, lipid levels, and lipid-lowering medications used in the U.S. population from 1999 to 2018, with point estimates in 2017 and up to March 2020. The interim data showed continued improvement in cholesterol screening, so that's good, with retrospective decrease in total cholesterol, triglycerides, and LDL cholesterol, with modest increase in statin use, but low uptake on non-statin therapy. And that's really what we're going to talk about mostly today, is the non-statin therapy. But this was very disappointing. Only the group of statin eligible patients with diabetes aged 40 to 75 showed an increase in statin use after 2015 to 16. And atherosclerotic cardiovascular disease patients, 60.4% were not prescribed a statin between 2017 and 2022. So that's the most recent data. Patients eligible for statins, less than half are being told that they need a statin. So that's on us to do a better job. This is another study that came out last year that looked at over 600,000 patients with atherosclerosis, and they were looking for who's really taking their statin. This population of patients had a mean of 67.5 years. Almost 20% were cerebrovascular disease, almost 70% were coronary artery disease, and the remainder were peripheral artery disease. So all of these patients were considered high risk. All of these patients should have been on a statin. And what they found was almost 50% was not on a statin, and only 22.5% were on the high intensity statins, with almost 30% being on lower dose or other statins. When they looked at the proportion of days covered, only 82% of patients took their statin more than 75% of the time, but 6.4% took their statin less than 50% of the time. And when they looked to see who was most likely to be on a statin and taking it appropriately, it was males, patients over 45, patients with coronary artery disease, type 2 diabetics, patients with hypertension, and those who had follow up with their cardiologist. Who was not taking the statins tended to be females, the older patients over 45, and those with cerebrovascular and peripheral artery disease. And often those patients aren't seeing a cardiologist or a preventive cardiologist, and they're really not getting the feedback of the importance of those drugs. Speaking of women who are not taking the statins, traditionally, if you look back, and this is a time chart from 1980 to 2020, and it's looking at all of the cholesterol trials, and this would be 50% males and females. You can see that the early trials didn't include any women. If you look back to CARE, only 14%, WASCOPS, AFCAPS, TEXCAPS, 15%. These were our early trials, and these were the ones I showed you with a 36 to 38% reduction. But as time moved on and we had some of these stronger statin therapies and trials aimed at lower targets, we started to get more women, and only two trials even begin to get 50% women, and that's PROSPER and ALLHAT. So when you talk about some of this data that says women don't benefit from statins, it's because women weren't included in the trials. And as we continue to include women in trials, we are seeing that women definitely benefit from statins as much as men do. But there is a large bias. So this was another study published in 2019 that looked at sex differences in the use of statins in a community practice. They had 5,693 guideline eligible statin patients, 43% women, 57% men. And when they looked at the data comparing women to men, women were prescribed statins less, 67% versus 78.4%. They received less intensity statins a little less often, with men getting them a little more. They were offered a statin by their physician less, 18.6% versus 13.5%. They more often declined the statin, 3.6% versus 2%. And they were more frequent to discontinue the statin, 10.9 versus 6.1, almost double the rate of women quitting statins. Interestingly, when they were asked, do you think statins are beneficial? Do you think it's important for your health? What men felt that statins were safer, 55% felt they were safe, but only 47.9% of women felt they were safe. And when it came to being effective, 68% of women felt statins were effective, but 73% of men did. And this was also statistically significant. So we may need to spend a little more time with our female patients, provide a little more education, particularly current up-to-date education on the importance of it to get them to stay on their statins, to take them and stay on the statins. So let's talk about side effects. So first of all, there's this huge effect of just negativity around statins. I tell my patients, if you Google statins good, you'll see millions and millions of articles. And if you Google statins bad, you'll see even more. There's just a lot of public opinion around statins. And we now talk about the nocebo effect. You all know about the placebo effect, where you think things are beneficial, even though they may be a sugar pill. And we have the same thing with statins, that there's this negative expectation of patients regarding the treatment, leading to reporting more negative side effects, and they don't want to take it. And they all have, you know, a story of a friend who took one dose of statin and they've been paralyzed for life ever since. And it's really hard to overcome these because they're talking about it frequently when they go out to dinner with their friends and these things. There is a huge statin reluctance currently. And so it's probably the thing that takes the most time in my practice is to bring up the statin, bring it up again in another office visit, talk about the benefits, get the patient to just agree to a 3-month trial and let's see what your numbers look like. There's a lot of negative expectation that affects this discussion. And then there's crazy books like this one talking about how statins and big pharma is killing everyone. But there are statin-associated side effects, and particularly the statin-associated muscle symptoms, or what I'm going to refer to as SAMs and myalgias. They actually are quite infrequent. In the randomized controlled studies, it's 1 to 5%. In observational studies, it's a little higher at 5 to 10%. And your older patients, your female patients, your low BMI patients, and patients taking other medications metabolized in the liver may have more problems. There's also a problem if the thyroid is hypothyroid or out of balance. There can be problems with renal and liver patients. And then Asian descent, patients who drink a lot of alcohol, and patients who do really intense exercise, the boot camps, the CrossFit, some of your highly athletic patients. Myositis or myopathy with a rise of CK, even 3 to 5 times normal, is very rare. And when it comes to rhabdomyolysis, a CK greater than 10 times normal with renal injury, it's also very rare. Statin-associated autoimmune myopathy, very rare. There were more cases reported in the past, some of them around simvastatin, but very rare in general. And then the thing that is valid that we have to discuss with our patient is the new onset of diabetes. Now, this doesn't take a patient who has perfectly normal glucose metabolism and turn them into a diabetic. What it is usually that patient in the pre-diabetes zone who already has a hemoglobin A1C of 5.7, 5.8, creeping up, particularly if it's around 6%. They are more likely to go on and manifest as a diabetic, going from pre to full diabetic. It's more common with the high intensity statins. It can be offset with weight loss and diet changes, but this is a real uptick in the hemoglobin A1C, and it is valid that we have to watch for that. The liver transaminases is very infrequent, to the point that if a patient's on a stable dose of statin and reports no symptoms, you don't have to continue to monitor the liver enzymes. Hepatic failure is very rare. A lot of my patients talk about brain fog, cognition decline. There are studies looking at that. One more recently came out that said that there's no difference in the randomized controlled trials compared to placebo. And when it comes to cancer, there's really no definite association. In the late 80s, early 90s, there was some studies that suggested that, but they are not conclusive with current meds. And then there's just a lot of unclear things: renal function, cataracts, tendon rupture, hemorrhagic stroke, interstitial lung disease, and low testosterone. The tendon rupture, I have seen happen in my patients with FH that have tendon xanthomas, and it could be that as the lipids are rapidly pulled out, the tendon loses its strength, but it's quite rare. This is a paper put out by Robert Rosenson with an approach that has a questionnaire of SAMs, of statin-associated muscle symptoms. And if a patient has a low score and they're being bothered, we'll discontinue the statin for a period of time. I usually discontinue them at least 3 to 4 weeks. And then maybe try the same dose of the statin. There's a good chance that they will tolerate it fine the second time. Studies have been published showing that. Or alternate the statin. Also continue to work on lifestyle. If a patient has a higher score, more symptoms of statin-associated muscle symptoms, you might check for a thyroid, check a vitamin D, give them a break, stop the statin, and then consider resuming a lower dose of the same statin or alternative high-intensity statin. And there's even some cases for going to alternate days, Monday, Wednesday, Friday, other days, if that works. See what else is going on with the patient and always work on lifestyle. And just this week in the European Heart Journal, there was a paper that says solid evidence that very few muscle symptoms are due to statin therapy. And some of the highlights of that, they looked at 19 large-scale, long-term, double-blinded, randomized controlled trials of statin versus placebo, almost 124,000 patients, 4 randomized controlled statin trials, and they were looking at more versus less intensive statins, and that was over 30,000. And in the statin versus placebo groups, with a follow-up of over 4 years, they found, get this, 27.1% complained of muscle pains and weakness in the statin group, but an equally robust number, 26.6% in the placebo group. And when they drilled down into the charts, only 1 in 15 reports of muscle symptoms were attributed to statins. I think this is really important. Almost a third of our patients, whether they're on statins or not on statins, are complaining of muscle weakness. And I talk to my patients quite a bit about that in the clinic of, well, how many aches and pains do you have when you wake up now? Well, you're still going to have them when you start the statin. Now that I'm past 50, you wake up and someday that ankle hurts, the shoulder hurts, and you maybe overdid it at a workout, or maybe you don't even know what happened. I think muscle aches are common as we age, and once you are on a statin, you want to identify that that's the cause. But I think your patient has to take almost a diary of how many aches and pains they have in a month before they start the statin, because that's the baseline that's still going to be there after they start the statin. Very interesting, there was no conclusive proof that the relative risk varied for various statin preparations, the hydrophilic versus the lipophilic. And I know we've all looked to that in the past as well. I'll switch you, but maybe it doesn't make a difference. And the different creatinine kinase levels was negligible, about 0.02 times higher than the normal limit from where they started with statins. So really, you can feel quite good that the creatinine kinase, the muscle enzymes are low, and the muscle damage is rare. All right, and some of my lipid tricks are to do alternating doses. Dr. Terry Jacobson wrote a paper years ago on this, and I've tried it particularly with atorvastatin and rosuvastatin, have the patient just take it Monday, Wednesday, Friday, maybe even just 2 times a week, and they find they can tolerate it. That little washout period between the days they take it seems to make a difference. So take it daily, ezetimibe when you're doing the alternating doses, if you need that to get the number to control. And don't forget about the bile acid sequestrants. While they don't do a lot, they're still quite helpful. There's still cholestyramine, cholecyvalum, which is all called Welchol, Cholestid, Questran. There's a Questran Light. These can also be used. And the phytosterols, just Metamucil over the counter, is sometimes something your patient's very willing to take. I do try to keep the vitamin D level between 40 and 90. And when we start checking these levels, despite being in Atlanta with a lot of sunshine, patients are wearing sunscreen, patients are working indoors, and I'm seeing levels in the single digits and frequently in the low 20s. So keep that in mind. Using vitamin D routinely, as well as coenzyme Q, has not panned out in studies, although I have individual reports from patients that it made all the difference. So I haven't completely chucked that out the window in a few cases. And then I tell my patients, feel free to take a statin holiday. If you're starting to develop some achiness, take a week, 2-3 weeks off, but get back on it. And many times after that little holiday, that washout, they're tolerating their meds just fine. And there are several patient education tools that can really help. I just picked a couple of my favorites. This is from CardioSmart. And one of the reasons I wanted to bring it up is this, this road here of shared decision-making. It is so important to keep talking with the patient, trying to keep them engaged and let them know if the statins aren't working, we have non-statins, which I promise I'm going to get to in just a second. This is put out by the American Society of Preventive Cardiology, and it's really helpful because it's 5 myths about statins. Myth 1, you don't need to take a statin unless your LDL cholesterol is extremely high. I still have patients who also think, well, my HDL is high enough to offset my LDL, and that hasn't been part of the cholesterol guidelines since 2007. So while it's great to have a high HDL, too many of the studies have shown boosting HDL does not prevent morbidity and mortality, and you need to have your HDL, your LDL, and your triglycerides all at goal. Statins frequently cause severe muscle problems. Well, I've reviewed that for you. That it's really very similar to placebo. Statins may cause brain fog, and I have several individual patients who insist that it really affects their cognitive ability, but as a group, the data is not there. Statins are only recommended to make money for pharmaceutical companies. Well, we all have to deal with that with all kinds of medicines. And then you don't need to worry about your diet or exercise after you're on a statin. And that's not true. Patients still have to follow the heart healthy lifestyle. So that's a myth in the other direction. And then this is put out by Million Hearts. I wanted to give a shout out to our own Larry Sperling for this patient education tool on how to deal with statins. And these are tear-off sheets you can have in your clinic. So the 2022 ACC Expert Consensus Decision Pathway on the role of non-statin therapies for LDL cholesterol lowering in the management of atherosclerotic cardiovascular disease that was published in JACC. I'm going to go through this for a few minutes. So as always, our highest risk patients have had acute coronary syndrome, a history of MI, ischemic stroke, or symptomatic PAD. And so really the cerebrovascular, peripheral vascular, and the coronary artery disease patients all need aggressive lipid-lowering therapy, generally with a high-intensity statin. And then patients' risk goes up as we age over 65, with, of course, 75 and 85 being even higher risk. The heterozygous familial hypercholesterolemia, or FH patient, we see a lot of these in clinic. I'm the PI on the Cascade Registry. So if you have FH patients, please send them over to Dr. Mehta or I or Dr. Isiadenso. We're enrolling them in that registry. But it's amazing. I'm seeing 3 or 4 a week in clinic. It's probably closer to 1 in 100 when we really start looking. Bypass patients are diabetic patients. And again, their new guidelines is below 55 for the LDL. Our hypertensive patients, our chronic kidney disease patients, patients still smoking, and those with elevated LDLs not to goal despite maximally tolerated guideline therapy. And then history of congestive heart failure, that's been very iffy with the lipid data, but if it is from ischemic cardiomyopathy, you definitely want to pursue that. So they've outlined an algorithm that basically, if your patient's not at goal, you want to try more approaches. You don't just give up, wave the white flag and say, okay, they can't tolerate statins. There's so many new ways we can go. And I'm going to take you to a higher inset of this to look at where they're really adding the extra non-statin therapies. So if your patient cannot tolerate the statin or their maximally tolerated dose is not getting them to goal, we want to think about ezetimibe. We want to consider adding the PCSK9 inhibitors. And we have 2 new drugs, bempedoic acid and inclisiran. The ezetimibe is now very easily, you don't have to do a lot of prior authorization or jumping through hoops to get that for patients. That's pretty easily, you just write the prescription and the patient gets it. But when it comes to adding PCSK9s, bempedoic acid, or inclisiran, there's a lot of hoops to jump through with prior authorization. You're still trying to get a 50% reduction in the cholesterol overall with an LDL below 70. And at times the patient does need to come see one of us at the prevention clinic or a lipid specialist. And don't forget, the registered dietitian is an important part of this as well. And always continue to monitor their lifestyle and heart healthy exercise routine and all of that. Also in these guidelines, they do recommend using the coronary artery calcium score. Again, this can be very, very important. If the score comes back 0 in your lower or moderate to low risk patient, and they are close to 65 older, I would really not worry about them so much anymore, except for one caveat. When the patient's LDL is still over 190, they are still at risk of fatty liver disease and some of the other lipid-associated problems. So sometimes they're going to need a statin even if they don't have coronary disease. Again, the score, if it's 1 to 99 and less than 75 percentile, then you want to go ahead and consider maybe increasing the statin. But if the calcium score is over 100 or the 75th percentile, you really need to go on to considering additional therapy. And they pointed out if the calcium score is over 1,000, you really want high intensity statin therapy. You may want to add on Zetia to that as well. And if they're a patient that you suspect is FH, you want to start to consider the PCSK9 inhibitors. So a coronary artery calcium score, I think, makes a great believer out of the patient. You can actually show them the pictures, you can pull it up. And as you can see, this is heavily calcified proximal LAD and proximal circ, and it's here in the aortic valve, and it's here in the descending aorta. And so when patients see this, they sort of have the epiphany of like, wow, this stuff is really happening, and can be very, very motivating, almost as much as an acute coronary syndrome event. And with the advance of coronary artery calcification, we do want to consider this subclinical disease almost as a bridge between primary prevention and secondary prevention. So we know that as the atherosclerotic plaque is building, it's going to get to a point that it limits blood flow, and now you're going to have ischemia and adverse events. And so we used to call primary prevention everything right up to that event. Secondary was after you had your stent, your bypass, whatever outcome. But now with calcium scoring and other atherosclerotic calcification, you want to think of this as like moving the secondary prevention to an earlier stage when this is detected. And another thing that's helpful is if your patient's already had CAT scans of the chest or the abdomen, and they've seen vascular calcification, calcium in the aorta, calcium in the descending aorta, even in the carotids or the cerebrovascular beds, that is a time to shift that patient as if they've already had an abnormal high-risk calcium score to a higher level of prevention. So not only can it be a coronary artery calcium score, any test detecting subclinical atherosclerosis really needs to jack up our treatment of them. So we have the statins, they've been approved forever. Ezetimibe or Zetia 10 milligrams is now indicated for patients as add-on therapy, patients post-MI, as well as cerebrovascular and PAD. And the PCSK9 inhibitors, they were initially added for FH patients and then patients who couldn't get to goal with cerebrovascular, cardiovascular, or PAD. And now it's easier just to use them as add-on therapy for patients who are not at goal. So aliricumab, which is the Praluent, it was initially approved in the United States in 2015. So if you're thinking, oh, these are new drugs, they're really not that new. And every year there's just more studies that increase their indications. So this is Praluent, and then Repatha and Evolocumab, also approved in 2015. And they just continue to get more indications for reducing not only lipid levels, but morbidity, mortality, and regression of plaque. So this is the final part of the guidelines, is if you have adults with clinical ASCVD at very high risk, LDL over 190, the first line therapy for non-statins would be the ezetimibe, the PCSK9 inhibitors, and bempedoic acid, which I'm going to tell you more about, or inclisiran. So everything is on the table for this high-risk patient. Your patients with clinical ASCVD, but not at high risk yet, they're also approved for ezetimibe and the PCSK9 inhibitors, and maybe bempedoic acid or inclisiran. Your adults without clinical ASCVD, but LDLs over 190. So this is, again, very likely your FH patient if they have the family history. Consider first-line therapy with ezetimibe and PCSK9. And again, bempedoic acid and inclisiran, and a new drug, evolocumab, for your homozygote homozygous FH patients, and I'll tell you just a smidgen about that in a minute. Your adults without clinical ASCVD, but with diabetes, again, Zetia, bile acid sequestrants, and maybe bempedoic acid. And your adults without clinical ASCVD or diabetes, again, Zetia, bile acid sequestrants, and maybe bempedoic acid. And if you're wondering about garlic and herbs and supplements, this study just came out, and they looked at fish oil, cinnamon, garlic, turmeric, plant sterols, and red yeast rice, and none of them compared to the LDL lowering you get with rosuvastatin. This is the rosuvastatin pile, and this is lipid lowering in patients. Nobody had higher lipids after they started rosuvastatin, and this was a low dose. In placebo, as expected, some people's lipids get better. That's probably intense diet and exercise, but most got worse. With fish oils, it can definitely make the LDL higher, so very few people had so a few people had increases, but mostly had benefits, and we see this a lot in the triglycerides. Cinnamon is not really doing a lot. These people aren't getting benefit. They had some lipid lowering, and there is some studies using this with the diabetics. As expected in garlic, they most all got higher numbers, but a few got lower. Turmeric's about the same, some lowering, but not a lot of benefit. Plant sterols, these are useful, and so as you can see, they had some lowering. And then red yeast rice, which does work on the HMG-CoA reductase site, just like a statin, had some lowering. But the overwhelming winner here is the rosuvastatin, and it shows that these herbs and supplements do not reduce cardiovascular risk and lipid lowering the way that a statin effectively and consistently does. And another concern as cardiologists is this is the cardiovascular deaths in America from the American Heart Association back to 1980 to 2010. We were generally going in the right direction with men, and finally we caught up with women. But as you see over the last few years, the AHA statistical updated data shows that we're going in the wrong direction again with cardiovascular disease. A lot of thought on what's going on here. Some of it might be attributed to obesity. We definitely have a hard time getting our patients to do physical activity, to do routine exercise. I all too often hear that they have an orthopedic problem or a back problem and they can't exercise, but most of these patients would be eligible for water aerobics or even chair aerobics, just some form of movement. And so we really have to encourage our patients to get moving. And then the ever increasing burden of obesity, it's getting worse in childhood and throughout adulthood. And so this might be part of why the cardiovascular risks are going up and the deaths. But again, we can work harder to control lipids in these patients. All right, so we're going to go through a case. This is a patient of mine, patient statin intolerant. Now what do I do? So a 62-year-old male with coronary artery disease. He had a family history of atherosclerosis. His mother had had an MI in her 60s, died after age 85. Father had died young, so there was very limited history there, and there were no siblings. His personal history is that he'd had an LDL in the 150s, definitely had low HDL in the 30s. His triglycerides had been under 150, no history of hypertension or diabetes. So his first event was at age 55. He had a STEMI with PCI to the LAD with a stent, but he had normal ejection fraction. He was started on pravastatin, and he had concerns about a high intensity statin. So we went with pravastatin, and his LDL never got below 103. The goal, of course, was under 70. He had leg pains, he had cramps, and so the pravastatin was discontinued. He wasn't to goal, so we tried rosuvastatin 10 milligrams, and he got myalgias with that, even when it was switched to every other day. He continued to have muscle aches. So he just wanted to stop the statins. He was kind of done with them at this point, and he said, I'm going to work on diet, exercise, and lifestyle. So does this sound like some of your patients? So the Mediterranean heart healthy diet is very good. It's low fat, it's plant-based, whole grains, lots of fish, olive oil, and he tried to stick with it. But as we know, it's really hard to avoid some of those comfort foods, your pizza, your hamburgers. And so sometimes diet isn't going to work. And his best LDL just following the Mediterranean diet was 113. Later, we tried ezetimibe, and because it blocks small bowel absorption of fats, it does tend to have some GI side effects. And unfortunately, he had those. We tried him on Repatha, evolocumab, 140 milligrams every 2 weeks. And maybe because he's very active, he's an electrician, so he's climbing ladders, he sometimes works in confined spaces, he's bending over, he continued to have muscle aches. And so we had to stop the evolocumab. He remained off meds again. He was trying diet and lifestyle. He was actually really motivated and a very compliant patient, but just couldn't tolerate the statins. He was working on the whole lifestyle, Life Simple 7. We were watching his sugar, blood pressure, everything. We were trying to keep it goal. And as you all know, the reason we say an LDL below 70 for coronary artery disease patients, because that's when you're actually getting plaque regression and decreasing events. And if the LDL's even above 90, 100, that's where most people in the ER are having a heart attack. That's the average US non-obese population. This is when atherosclerosis is developing. So unfortunately, 6 years later, he has recurrent angina and acute coronary syndrome, heads to the hospital in the middle of the night, and ends up having a heart cath that shows significant progression of his atherosclerosis. He had a 95% proximal RCA, a 75% proximal mid RCA, and ended up with multiple stents. So now he's very motivated, like, I can't have this happening every 5 to 10 years. He goes back on rosuvastatin every other day, and dang it if he doesn't feel achy and stiff and had to stop. So by this time, bempedoic acid had come on the market. It's known as Nexletol. We tried him on this. And bempedoic acid works in the cholesterol pathway. It blocks where citrate is converted to acetyl-CoA. And so it's earlier in the cascade than a statin and HMGA-CoA reductase inhibitor. And it's approved, and it's 180 milligrams once a day. And it is useful in patients who are intolerant to statins or not at goal on the statin. And they've looked at statin tolerance in this in several trials, and the side effects is quite similar to placebo in all these trials, really quite tolerable. And the LDL reductions, 26 to even 43% in these statin trials. So it is quite effective. So our patient was started on the bempedoic acid, and his best ever LDL 87, non-HDL 112, HDL 36, triglycerides 138, and more important, he can take it, he can go to work, he can function, he's happy. His cardiologist is happier than he used to be. He's still working on guideline-directed therapy. He reports good quality of life, and every step of the way, shared decision-making and great communication with the patient was essential. There are some new options. You all may have heard about Leqvio or inclisiran. It's a small interfering RNA that reduces cholesterol. And then the new only on the market monoclonal antibody is the Evkeeza or evolocumab. These were also mentioned in the non-statin guidelines. The big problem with these is cost and access and even challenges to the healthcare system. Leqvio is an injection that has to be given in the clinic. And so who buys the injection? How does the hospital system make sure they get reimbursed? All of these things have been a real challenge, but I am happy to announce that we do have Leqvio going at the prevention clinic at Executive Park, thanks to Dr. Isia Denso's leadership. And so this will be more of an option as we move forward. Inclisiran was in quite a few trials in Europe. but became available in the United States in 2020, 2021, and is now available as add-on adjuvant therapy for atherosclerotic cardiovascular disease, but is also available to heterozygous and homozygous FH patients. This came out of the European Heart Journal. About 50% reductions in LDL as well with it, and good tolerability, good safety. And if you're wondering, where do these things work? Well, PCSK9 can block the LDL receptor and degrade it so the LDL stays high in the blood vessels and isn't getting into the cells. PCSK9 inhibitors block that attachment to the LDL receptor, so the LDL receptor can take up cholesterol into the cells for use. The analogy I give patients is think of it as a little bit like an insulin. Insulin tells your cells to take up the glucose so it's not in the bloodstream and it's utilized in the cell. The PCSK9s allow the cell to take up the LDL and get it out of the bloodstream as well. Inclisiran works to attach to the PCSK9 and also block it from attaching. So we have two pathways now, interfering RNA with Leqvio or inclisiran and the PCSK9 inhibitors or blockers to allow the LDL to be removed from the bloodstream more easily. The evinacumab is extremely expensive, anywhere from $11,000 to $16,000 an injection, and it's once a month. So the healthcare system is definitely having challenges to dealing with this, but it is important to know that this is one more option for our homozygous FH patient. And I do want to take just 2 minutes to talk about FH. It is so underappreciated and so common. As I said, I'm seeing 3 or 4 patients a week. The key is the LDL over 160 in children, over 190 in adults with a strong family history. And we definitely want to get them enrolled in the Cascade registry. So the family history is key here. Again, if we can intervene, this is a 10-year-old, a 20-year-old, if we can get their LDL down, we completely change the trajectory of atherosclerotic production and their outcomes and even quality and length of life. Currently, FH treatments have been dietary, lifestyle, and statins. I actually have some FH patients who LDLs are way below 100, some even below 70, just with high intensity statins. So many of them are responders, but again, we use ezetimibe and the bile acid sequestrants. The PCSK9 inhibitors were approved for this. We use lipoprotein apheresis, and we still have that through the prevention clinic. And now the Evkeeza is new on the market. We just have to find it affordable for our patients. So in summary, please maximize diet, exercise, and lifestyle. Use alternating doses, changing statins, lower dose statins intermingled with higher dose statins, statin holidays. These can all be very effective. The bile acid sequestrants are helpful, ezetimibe, the PCSK9 inhibitors. Consider bempedoic acid. It worked like a charm in my patient and is quite tolerable. And then we'll see how the Leqvio new option works out for us. And remember that nobody's going to care about your patient's cholesterol like a cardiologist. Too often primary care is so burdened with everything else they have to do, finding out if you had your mammogram, your colonoscopy, your prostate exam, but really it's the cardiologist who has time to really focus on those lipids. And I want to remind you of Apollo 13, failure is not an option. There are so many non-statin options out there. Please consider them. And if this isn't your thing, please send them to us at the prevention clinic. I'm happy to see them in my clinic. And just a final reminder that this Friday is Go Red for Women, Women in Heart Disease. Please, everybody, wear your red on Friday. And I'm done with just a couple of minutes for questions.
Thank you so much. That was excellent and a great case. While we are waiting for questions, let's see if I can type them out in the chat box. I'll go ahead and ask you a question. Are you ordering the advanced lipid testing, the Berkeley Heart, and when are you doing that? Because I get asked that question a lot in clinic.
Well, a couple of places. So where I think it's most useful, and it's now called the Boston Heart Lab. It's no longer called Berkeley. When you have a patient who seems to be doing everything right with diet and exercise, and they are on guideline-directed therapy, and their numbers look good, that LDL's, 60, 65, and they continue to have events, that person needs advanced lipid testing. They might have cytostarolemia. They might have high LP(a). They have something more going on. That patient, I think, really needs it. Where I don't think you need it is the patient who hasn't even gotten their LDL to goal yet, and they're wanting to know, well, is it the large particle or the small particle? I tell them it doesn't matter yet because you haven't gotten over the first hurdle to start refining the tiny details. And then I also worry about that patient who comes in and says, my dad had bypass surgery at 38, my mom had a heart attack at 42, that really premature atherosclerotic family, they've got stuff going on. And with the advanced lipids, you could look at the ApoE. You can check the different genes for other high-risk markers. 9p21 is associated with more aggressive heart disease. And it gives you a level of where to be aggressive, because the calcium score before age 50 really isn't that helpful. If you do a calcium score on a 40-year-old, you're going to get a 0, even in a high-risk family, high-risk patient. So I don't think everybody needs an advanced lipid, the highest risk person, and the strong family history.
Great, thank you. Dr. Chang has a question. Great talk, Gina. How do you deal with the A1C elevation with high intensity statin? So for example, if a patient is on rosuvastatin and hemoglobin A1C increases from 5.9 to 6.4 despite aggressive diet and weight reduction.
Yeah, it's very frustrating because one, the patient was in the pipeline going there even at 5.9, but then now you're 6.4 and you're fully diabetic. I'm a big proponent of patients, particularly that need weight loss, of trying to get them on Trulicity or Ozempic to help with the weight loss and control the sugar. We're doing a lot of that in my clinic. I think it underscores the importance of exercise and diet with this. But I just tell them, I think you were headed here anyway. I'm sorry we got there a little faster, but now you're going to get more aggressive treatment. I haven't seen it go up like 0.5, but the studies usually show the hemoglobin A1C can go up 0.2 to 0.3%.
Okay, thank you. Dr. Izzy Denzo has a question. You can go ahead and unmute.
Thank you. Gina, thank you for such an excellent talk this morning. You covered the gamut of some of the challenges we faced and some of the work that still needs to be done. I did want to share with the group that we did give our first dose of inclisiran Leqvio last week in clinic. So that is something to be proud of as we continue to navigate some of the challenges in, as you mentioned, getting this approved, because it does go through the medical insurance, but we're learning as we go along, and we've got the second injection hopefully coming up within the next few weeks. My question for you is, you so adequately discussed some of the challenges in statin adoption amongst our female population. And I find that that age group 40 to 60 is where I have the greatest difficulty. And amongst men and women, we are fighting really an uphill battle, trying to counter information that our patients come to us with from friends and from online resources and their social groups. Do you find that focusing more on a lifetime risk actually makes that impact with the female patients in increasing their awareness of their cardiovascular risk and their interest in statin use? Or do you think we need to focus on overall just dispelling some of those myths regarding statin use?
I think it depends a little bit on the patient. So when I'm talking to, let's say, a 55, 60-year-old, and I tell her, your lifetime risk is 5 times that of the woman your age, and you can just show them that, on your app. I do the app on my phone. They're pretty motivated, but that 40, 45-year-old woman, to her, 65 and 70 is still a long way away. And I think as a society, we're so immediate, right? Like what's on our plate right now and what happens in 20 years, I'll worry about then. So I don't think it's as motivational in the 40-year-old. I think they just feel like, well, I'll deal with that then. I don't want to be on a statin for 20 years now. But I do use this little analogy, is that if you're going to be on a statin for 20 years, anytime in your life, Why take it from 60 to 80 when you've already developed disease and you're just managing it? Why not take it from 40 to 60 so that you don't have it at 60 and then you don't have coronary disease? And sometimes that type of thinking will motivate the younger woman is, you know, like, well, if I do it now, I'm safe later. If I wait till later, I'm already in trouble. That's just my trick.
Thank you. We have one last question before we're going to close, and that's from Rob Wilson. If you have a non-diabetic primary patient, primary prevention patient with a CAC score of 0, what are some of the things that you look for to see whether they need to go on a statin or not? So what are some of the risk enhancers that lead you to recommend a statin in a non-diabetic patient with a CAC score 0 for primary prevention?
So again, I think it's about their age. If they're 40, they probably are pretty low risk. And if they're 65, they're higher risk just because of the diabetes. But you know, in a female, I would ask about adverse outcomes of pregnancy. I might go ahead with if there's a strong family history and check the Lp(a). I might add a CRP, although I'm not that big on it. It tends to be higher in obese people. But I think, again, it's, you know, diabetes is never okay. You know, it's a lifetime of high risk. I try to educate them on the risk with diabetes. And sometimes just, you know, tracking the LDL over a couple of visits that, you know, you're nowhere near where it's supposed to be. And again, the ADA guidelines just went to under 55 as an option for their high risk patients. So I think it's really about re-educating them that you're not a little pregnant, you're not a little diabetic. Diabetes is always a high risk situation, even when it's well controlled.
So question was for a non-diabetic.
Oh, I'm so sorry.
That's okay.
Yeah, non-diabetics, I would worry a lot less about at 40. I really focus a lot on lifestyle, and them I would want the LDL below 100 if possible. I might not start them on a statin until it's higher, like 130s. But I think lifestyle it's just so hard because you got to do it every day. And the vast majority of our patients don't do it. I would look at their BMI, check out their diet. I try to get patients to be as vegetarian-like or pescatarian-like as they can.
Okay, great. Thank you so much. Thank you everyone for joining. We are past 8:30, so I'm going to go ahead and close. Have a great week, everyone, and I'll see you next week.
The preceding program is copyrighted by Emory University.